All right. Good afternoon, everyone. My name is Cynthia Klein, and I serve as the Project Director for Take Heart. On behalf of our entire team, I'd just like to welcome you to today's webinar. This topic is something we've been really interested in bringing to you for a while. So being able to bring cardiac rehab to heart failure patients is something that's been on our minds for a while. We've been talking through how best to do, and we're really excited about the panel of speakers we've brought to you today. Just a couple of quick updates on Take Heart before we get started. So we've been really busy within the Take Heart program. For those of you who are serving as partner hospitals, our first cohort is nearing the end of their training program. So they've completed Module 8, or just about to complete Module 8 of a 10-module series. And we've also kicked off a new cohort of partner hospitals just recently. And they will be starting into the training program starting this month with Modules 1 and 2. As a reminder, we are continuing to do these learning community affinity groups along the way. So you have the one today. The events are open to anyone, and we do have information on past events. If you're interested in past materials, those are available on the website at the link here. Just a quick reminder for today's discussion, we do have the moderated panel discussion, and we'll put you through some tips on how to do the chat and the polling going forward here. And now I'd like to go ahead and pass you over to Steve Hines, who's going to do some introductions for today. Thanks.
Thanks, Cynthia, and good afternoon, everyone. I'm delighted with the panel that we have sharing with you this afternoon. That includes Skali, who is the principal investigator for Take Heart, Stephen Keteyian, who's the director of preventative cardiology at Henry Ford Hospital. Michelle Young is an adult nurse practitioner in the cardiovascular division at Brigham and Women's Hospital. And then Daniel Forman, who's a cardiologist at the University of Pittsburgh Medical Center and elsewhere. And all of our panelists today have had extensive background in understanding and helping heart failure patients in cardiac rehab programs. So we're delighted that they're able to share with us today. We want to encourage you to be actively involved in this event. And you can do that using the chat function and to ask a question or comment, to open the chat box, and make sure that you set the to field to everyone so that the panelists can see your questions, your peers can see the questions, and we'll be able to respond to all of them we can. And if you want to try it to see if it's working, we'd encourage you to just take a second and type in if there's one thing that you were hoping to get out of the event today. Just enter it into the chat. Our panelists are very interested in that, and we'll try to make sure that we address as many of those issues as we possibly can. We also like to do a bit of polling during these events because it helps our speakers to see where you're all at, and it gives you a sense for where some of your peers may be at as well. So you can poll using the polling function, and you just pick the option on the right-hand side that most aligns with your views. So let's do a first polling question. And we're interested in how you describe the involvement of heart failure patients in your cardiac rehab program. Do you actively discourage them because you have concerns? Do you welcome them, but very few actually enroll and participate? Do you have some, but they drop out? Or do you tend to have ones that participate in good numbers and with equal levels of success with your other patients? So pick one of those four options, and in just a second here, we will close the poll and see where you're all at on this question before we move on. All right, so if we can close the poll, and we'll take a look at the results and see where people are at. Takes a second for the polling responses to load up, but hopefully we'll get them here shortly. And there we are. Some heart failure patients, it seems like the most common response is that they participate and do as well as the others, which is great to see. And then a number indicate that they welcome heart failure patients but don't have a lot to attend. So we'll try to address both of those issues on the call or on the event this afternoon. And let's just do one other question. As you think about your cardiac rehab patients, what's your top priority for improving the care of those patients? We're interested in your primary reason for connecting to this call this afternoon. So increasing the number that get referred or encouraging more of those referrals to actually enroll and participate, making sure that they're safe during the events, or helping heart failure patients actually finish their program and maximize their benefit from it. So take just another second and pick your response, and then we can display the answers here before we dive into the presentation. All right, let's see where you're all at as a group. And in the meantime, we're getting a few comments in the chat, which is great to see. And it's great to see a really good number of people on the call today. All right, so it seems like the most common goal is encouraging more eligible patients to enroll in cardiac rehab. That's critical, and then that's followed pretty closely by increasing referrals and also helping heart failure patients to succeed once they're in the program. So we'll make sure that we address those issues, and if specific things come up related to either of them, by all means, we will make sure that we address them and ask our panelists to respond to other questions or comments that you put into the chat. At this point, I want to turn it over to Hisham, who will guide us through today's discussion. And you may need to.
Thank you. Thank you, Steve. And thank you, everyone, for joining us today for this very exciting webinar here. I'm delighted to be with my co-panelists here. And we'll have, I think, a very lively and enriching discussion for everyone. One point, just to follow up on Steve's polling questions, we only had about 60 out of 120 people who actually answered their polling. So I want to make sure that everyone is actually engaged and involved with this. Please feel free to add any comments that you have in the chat box so we can make this very interactive and enriching for everyone. And so I'd like to welcome you today. The structure we're going to adopt today is going to go over the journey that we have over heart failure, of our patients enrolling in cardiac rehab or getting into cardiac rehab. So we're going to talk about some strategies to encourage more referrals, and then how do we enroll patients successfully in our rehab programs, and then how do we help them continue, participate, and complete their participation actually in the program, and what kind of tips would we have in evaluating this, and how we would set up a model for a successful program all over. So with that in mind, I think a couple of things that just sets the stage. This is not going to be the focus of our discussion, but it helps set up the expectations and really clarify any misconceptions for this. We set up this slide with the help of Karen Louie, who's, I'm sure, very well known to many of you because of her many years of advocacy and actually professional involvement with cardiac rehab and AACPPR. And so we tried to clarify here what are the things that make patients with heart failure eligible for cardiac rehab. So patients with heart failure can be eligible for cardiac rehab if they have any of the other diagnoses that already make them eligible for cardiac rehab. So if they had another MI, if they had an MI, if they had bypass surgery or revascularization, if they have any kind of valve procedure, that would automatically make them eligible for cardiac rehab, regardless of their heart failure status, regardless of their ejection fraction, and so on. So we should seize that opportunity to enroll these patients and refer these patients to cardiac rehab anytime we can. The other thing that the documents and the official text mention is that these patients have to be stable for 6 weeks. They have to have an ejection fraction of 35% or less, and have had heart failure NYHA class 2 to 4 to be eligible. So those are the three things, other conditions that they have to be eligible for referral to cardiac rehab. And one thing to make clear is that eligibility does not require prior hospitalization. These patients can have heart failure, they can be treated in the outpatient, seen in the outpatient setting, and they can be referred directly from there into to a cardiac rehab program without having to spend a single night in the hospital. So again, that essentially broadens the number of patients that we can refer to cardiac rehab. Despite all these points that are clear now, there remains some other aspect that might be a little fuzzy and are not necessarily obvious from the get-go. So we talk about 6 weeks of having a patient stable, but we're not sure when does that 6-week period start, actually. It's easy if they have an index event such as a hospitalization. We would say, well, they have to be 6 weeks stable for 6 weeks after they've been admitted. But if they haven't, what makes it, what starts the clock at that time? Also, the clock does not start with any admission. If they get admitted for anything else, if let's say they get admitted or they have a hospital visit or an emergency room visit for something else, they fell, they have a wound and they need stitches and they get seen in the emergency room, that does not start the 6-week clock because of that ER visit, right? We talking about stable for 6 weeks because of their heart failure event, not because of any other unnecessarily of another medical visit. What happens, or what will we do if someone has heart failure, has an ejection fraction of less than 35%, but then they have an echo checked within a few weeks after their discharge or in follow-up, and that echo shows an ejection fraction greater than 35. It improved to 45, 50, or 55%. Does that make them eligible necessarily for cardiac rehab? Well, if you have a documentation that shows that the ejection fraction has improved, actually, it might be hard to argue that given the new information that they are still eligible for cardiac rehab. However, if you don't have that information and their ejection fraction was known to be less than 35%, you referred them to cardiac rehab, they are participating of cardiac rehab, having another echo later on does not necessarily cancel out their eligibility and their participation in cardiac rehab. Another point that's unclear, but that's always actually, that's often raised, is what happens if someone has another event and does that make them eligible for a cardiac rehab? We know that someone who has a stent in a coronary artery and they are referred to cardiac rehab, they can complete their 3 months of participation. 6 months later, they have another event, they get another stent in another artery, they can again be referred to cardiac rehab. Well, similarly here for patients with heart failure, there isn't a clear limit in the amount of time that these patients can be referred to cardiac rehab. It is very plausible and logical, and actually we would say that if the patient has a recommendation for cardiac rehab, meaning that they have their heart failure, their NYHA between 2 and 4, their ejection fraction is low, and they have been stable, you could make the argument that you can refer them again for cardiac rehab, and they can derive all the benefits that we're going to describe in details in a few minutes. Karen Louie was very actually encouraging, and I think we should really seize her words in being hopeful that the best thing we can do for these patients is actually refer them to cardiac rehab, and then we can figure out and advocate and actually appeal to CMS and Medicare so that their treatment is being taken care of. If we don't do that, then these patients are not referred. They don't even get to be in the system. They don't even get to be evaluated. They don't even get to benefit the least bit of what we can offer them. So I think the least we can do is refer them and have our system work to help them benefit from the cardiac rehab coverage. There are other things that patients can benefit from cardiac rehab, and it's not just exercise, it's also other counseling, medication monitoring, and so on, and we'll go over these details. And patients with good management and who are being taken care of by a good team in the hospital and outside can benefit from cardiac rehab-like activities during that 6-week period before they get in the system, and we're going to go over this as well. So I hope these points were useful in clarifying some of the misconceptions you might have. And I'm going to open the panel now, talking about some of the other things, and in bringing my co-panelists here to clarify and help convey the points that we can use to help our patients. So let's talk about encouraging more referrals and what are the things that we think are not working or may not help our cardiac rehab patients. Let me ask Michelle first. Michelle Young is a advanced nurse practitioner and works specifically in the advanced heart disease section as well as in the cardiac rehab program. So it's really hands-on, frontline working with patients, both on the referring end and on the receiving end for cardiac rehab and heart failure. So Michelle, thank you for being with us here. Could you actually talk to us about some of the misconceptions and some of the confusing part about eligibility for patients with heart failure?
Thanks, Hisham. I think entirely you've based upon a little bit of clarifying the eligibility for our patients who have heart failure. And I think there's a lot of times a misunderstanding that providers have if they're going to be eligible or not to start cardiac rehab. I think in general, there's a lot of misconceptions about the benefits of cardiac rehab for our heart failure patients. And some of those benefits are similar to any other cardiac patient, or as well as just for hospitalizations in itself for heart failure patients. We've seen a limited or decreased number of hospitalizations for all of these patients. Their functional capacity tends to get much better after completing a program, and their quality of life actually improved. A lot of heart failure patients don't feel that they have the ability to exercise, so just participating in this program or any cardiac rehab program actually allows them to see and get that support that they are able to exercise.
Thank you. Yes, no, it's important to remember that these patients will benefit from their participation on many aspects. So with that, let me ask Dr. Forman. Dan, I think you and I have known each other, and you don't mind me calling you Dan. And you've been working in this field for many years. So could you help describe the many benefits that patients with heart failure can derive from participating in cardiac rehab?
Yes, thank you. One thing to highlight is that my background is both in cardiology and in aging, and as a geriatrician and a cardiologist. And so I think a lot about aging, but it's not exclusive to old age that many people with heart failure are struggling not only with the fact their heart is weakened, but it's associated really by pathophysiology to comorbidity, to polypharmacy, to really great complexity of care, to frailty, intrinsic weakening from both heart disease and frankly the fact that many heart failure patients are older. So I think the concept of cardiac rehab really started when it was for patients that were recovering usually from surgery or a heart attack, with the notion that an event happened and they were going to get better, especially after surgery or a stent. With heart failure, it's often very different. These are people that are struggling with a change of their bodies and their function that's much more progressive and insidious. So cardiac rehab provides an opportunity to really address this in a very different way, a lifestyle change. It's more fundamental, and I think patients that don't get this benefit really often progressively decline. So heart failure is a time, as had already been said, to think about exercise with a notion of not necessarily going longer on a treadmill. That's kind of an abstract concept. This is a concept of actually living in your home, staying independent, understanding your basic symptoms when you exercise, so you know your body, so you feel a little bit more confident that you can walk up and down the stairs, you can go to the supermarket. So function really is not just exercise standards that you might traditionally think of, but really maintaining independence despite complexity of disease, which doesn't usually have a magical treatment that a cardiologist or a surgeon can implement. So it's living with the heart failure, it's living with multimorbidity, it's an opportunity to get your medications aligned and organized. And just to mention a few other really important points, patients are usually bombarded by different things about salt and other aspects of nutrition. So it's an opportunity to think about your diet and navigating a restaurant and how do you order. So there's so many aspects of basic lifestyle that I would assert are very important for heart failure patients in general, and particularly the growing predominance of older heart failure patients. But even younger patients struggle with frailty and struggle with all these complexities that I've just described.
Thank you, Dan. Yes, you're right. It's not just how long they can walk on a treadmill, but it's all these other benefits that you've described very well. Dr. Keteyian, Steven, so thank you also for being with us. Could you describe and talk to us about some of the risks and associated with that we can for these patients, and how we can how these patients are really suitable and how the program is suitable for these patients rather? I think you're on mute. I'm sorry, Stephen.
You think I would have had that organized by now, right? So thanks for having me, and I'm happy to address it. The first thought that comes to my mind is the eligibility criteria, and you alluded to that. These patients are on stable medications. They are identified as patients that are eligible and referred and eligible to come into cardiac rehabilitation. So although they tend to be thought of as a higher risk group, they're still somewhat garden variety cardiac rehabilitation that we're going to engage these patients in. Now, having said that, and this was clearly more of a concern, let's say 15 years ago, before the HF Action trial really got underway, there were many concerns about the risks of exercising these patients either in a supervised setting or at home. But as HF Action showed quite nicely, that the so to speak event rate or the adverse events or major adverse events in a treatment group versus the control group were no different. Thus, engaging these patients in exercise was a safe undertaking, and we should think about that as we move these patients through our program. You had mentioned also, or someone had mentioned that, or Dan had mentioned that these patients come in with a lot of comorbidities. Well, all of our, not all, but many of our other patients come in with a lot of comorbidities, whether it's AFib, obesity, diabetes, hypertension. So these patients with heart failure come in with that as well. Therefore, they're really suitable for being observed in cardiac rehabilitation, the case management and the disease management that goes on with cardiac rehabilitation in terms of medication compliance. This fits very nicely into caring for these patients with heart failure. So I would advocate, as many of you probably know for me, that heart failure is the right place for, cardiac rehabilitation is the right place for heart failure, and we can do a lot for them beyond just exercise in terms of their overall care.
Very nice. Absolutely. So as you said, a lot of our patients come in with other diagnoses, but the profiles are very similar from one enrollment diagnosis to the next. So in talking about this topic of referral, how do we broaden our outreach? How do we get to the referring physicians, the primary care, the other sources where we can get these patients from? Dan, could you talk to us about where we should, what door should we knock on? Who should we talk to? Who should we address?
Yeah, thanks. I think it's a great question. The traditional answer, and I think it's a good answer, is the physician, the primary care physician and or the cardiologist should be advocates of cardiac rehab. And that's often not the case. I think that physicians often get preoccupied about the medications and about a variety of other factors that are relevant in the acute management. And the notion of emphasis on cardiac rehab often gets lost. So I think that is still an opportunity to really reinforce physician education and prioritization. It's interesting for me in our program, if you ask the patients that participate, it's somewhat of a selection bias, but if you ask them, they rank the cardiac rehab as one of the most valuable aspects of their care. It's hospital to home, it's an enrichment, it's self-efficacy, it's a tremendous enhancement of their lives. If you ask physicians about cardiac rehab, it's very rarely ranked as a top priority. There's a lot of other priorities that fill them. So I feel like physician education really is important. But the other part of your question, which I think is also very important to emphasize, is that it's a care team. It's the physician, yes. It is the nurse. It is the physical therapist. It is the nutritionist. It is everyone that touches that patient to have a uniform outreach to cardiac rehab. And I think it's a mistake that somehow this gets allocated to one person in the care team to mention cardiac rehab, usually with a pamphlet as they're going out the door and they're bombarded with so many other things to think about. But I think if you really make this a focus, a central priority of organization that really facilitates the transition to the rest of your life, there's a lot of opportunity to improve the enrollment.
Excellent. Yeah, no, so you're right. It's really one of those things where the more we repeat it, the more people say it, the likelier it's going to happen and great and yield more success. As you guys were talking, I was able to look at some of the comments in the chat box. I had a lot of participation there, and some of the points we're going to address in the upcoming in the next few minutes. We have Becky from a member of Mended Hearts. Hi Becky, thanks for joining us there. So this is again another actor in the community and increasing the outreach for these patients. Someone commented that, as we discussed in the beginning, that patients with heart failure are actually participating in cardiac rehab, but not because they have heart failure, but because they have some other diagnosis. They're almost as if they're coming as if they were incognito. And so that's to your point, Stephen, that we've already been taking care of patients with heart failure in our cardiac rehab program. So this doesn't necessarily make changes the patient's profile or anything. It's just that we have to be aware of them and we have to increase their participation as well. Someone else commented about, what does stable mean? And that gets us to the next point here. Okay, so what strategy? So Michelle, how do you define stable for 6 weeks? And what can we do during those 6 weeks?
Yeah, I think that's the really important question, is what is the 6 week of stability, and when does that 6 weeks start? So ideally, if, like you mentioned earlier, if we had a heart failure patient who's hospitalized, then the 6 week can start at that time. But I think we lose track to really when our heart failure patients are stable, because if someone is hospitalized, they're optimized on their medications, they're diuresed. When they leave the hospital, they're technically in a euvolemic state, and they're much more stable than they often are months and months later. So I think waiting the 6 weeks is what the guidelines are recommending us that we do, but there's a lot that can be done within those 6 weeks. So I do think early referral is important, and hopefully we can get hospitals and physicians upon discharge to send a referral along at the discharge time. And so that way, once the referral gets in, gives you lots of time to orient the person to the cardiac rehab program, start the intakes, start them early. So therefore, you're not wasting the 6 week time. Get those intakes done by each discipline and get them ready to start their program.
Excellent. Stephen, what can we do also during those 6 weeks, and who are the patients we should target earlier than others?
A good question. Everything that Michelle mentioned, it has to be reemphasized. There's that 6 week window where our education can start. It's not a switch that just flips at 6 weeks. We can start our education very soon after hospital discharge, 2 weeks, 3 weeks. We can have people come back and engage with the nutritionist, the dietitian as well. The point here is every patient's different, and our initial phone calls with patients, our initial touches with patients, we become part of their disease management process. Many of these patients may or may not, or some of these patients may or may not see their primary care physician in 2 weeks or 3 weeks or 4 weeks after hospital discharge. So we can play a role in terms of symptom assessment, answer questions, pushing them in quicker to their primary care if need be. All this can happen in this interval that is happening between hospital discharge and 6 weeks, so that when 6 weeks hits, our first exercise visit can be planned, scheduled, and begin if everything falls in line, and the billing can start for CMS, et cetera. The last point I want to mention is that as we tend to get focused on this 6 weeks and think about hospital discharge, Dan had mentioned, or you had mentioned, A lot of patients get referred, or some patients get referred from outpatient care or the ambulatory care setting. These patients don't have to wait 6 weeks to get into cardiac rehabilitation. Plug them into your orientations, get their education started, and get them started in cardiac rehab.
Excellent. And I wanted to mention for those who don't know, Dr. Keteyian Stephen here is very familiar with the 6-week period. He was part of the team that put together the HF Action trial that led to heart failure being reimbursed by CMS as a diagnosis for cardiac rehab. So, yes, Dan.
I just want to make one additional point, in addition to the ones that have been wonderful comments that have already been made, is that the hospitalization period is for many heart failure patients is a time of tremendous deterioration clinically, from being sedentary, from being deconditioned. So in addition to the organizational strategies that have been emphasized, I think just encouraging people to get out of their chair, not necessarily to exercise, but just to be mobile so that the spiral downhill does not continue, I think is really an important opportunity. And this notion of 6 weeks is still very much a topic of research, and I know there's strong arguments in different directions about what's optimal. But I think the notion of just sitting in a chair is clearly not beneficial, and I think we could really intervene on that.
Yeah, and maybe that's a very good point, Dan. And so I think one of the things to talk about this 6-week period, and I was reminded by that by one of the comments in the chat box here about what is it, what it isn't, what is not 6 weeks of stability. So it's really when you don't have a deterioration. I think that's the main point, is that when you're not expecting this patient to come back, when you have someone who said, well, you're very tenuous, and I think you're going to be back in the hospital in the next 2 to 3 weeks because you're not making any progress. So you don't want to refer that kind of patients to the cardiac rehab program. You don't want their participation in cardiac rehab to be interrupted in the middle because they've been already deteriorating. So one of the comments in the chat box was about, how about patients who are on inotrope drips, for example, in the outpatient? Some people have a central line and they're already, or PIC, and they're already on inotrope drips actually, but they've been on the same dose for weeks on. And so that would be considered stability. And if you can improve their functioning and improve them with their, help them with their ADLs, that patient would not be contraindicated to go in and to be referred to cardiac rehab, because even though they're as sick as possible, they've been extremely stable, and that's their baseline where you can improve upon. It's not a trajectory that's going downward. I think that's the point that we want to keep in mind.
And Hisham, you could make the argument these people that are quite sick, the ones that are on inotropes, they walk in from their clinic appointments, they walk around the house, they may walk around the grocery store a little bit. Why not have them walk with us in cardiac rehabilitation in a safe setting and a monitored setting where they get all the other education and information as well?
Yes, Michelle, go ahead.
And I'll make another comment on that. I think in regards to having patients on inotropes, a lot of these patients who are home on inotropes actually have ICDs. It's one of the guidelines that they have an ICD. So they're protected. Not that you want to get them to the point where their device is going to fire, but they have an additional protection. And I think in regards to looking at stability in those 6 weeks time, we have to be open to the fact that a lot of heart failure patients will have their medications adjusted to reach those optimal targets of medication. So while you're optimizing their goal-directed medical therapy and their providers are doing that, you don't need to necessarily wait 6 weeks from each dose to be optimized, because that's a continuous trajectory of medication adjustments. And as long as their volume status and their symptoms are stable, I think that's what you should go with, and not necessarily being on a stable dose of medicines, because those are going to constantly change. And then lastly, I think when you look at what their medication regimen is for these heart failure patients, we now have 4 medications that our goal is to get these patients on. But I really think in the next guidelines that come out from the Heart Failure Society, we should look at having our 5th medication or our 5th goal to actually be cardiac rehab for all of our patients. I really, really think that's an optimal goal for every heart failure patient.
I'd like to follow up with one point that you just made, Hisham, that when you mentioned just walking, or Steve, you made this comment, I apologize, that just walking in the cardiac rehab program, I really want to emphasize the experience that I've had, and I think many will describe, is the fact that it really builds individuals' confidence. In other words, they may walk at home. You could say, well, why do you have to walk in cardiac rehab? It's because the guidance of having medical supervision, feedback, the reassurance, seeing what other people are doing that have similar circumstances, knowing that there really is opportunities for recovery that may not be self-evident, I think is really important. And the literature highlights the fact that people who are the most frail, the most encumbered, often benefit proportionally the most. It really is the critical difference of having enough function to stay independent. It's a life-changing opportunity. So it's not just like tweaking, your performance so you're a high intensity athlete. This is really staying independent. So this incremental benefit is actually proportionally huge in the lives of many people that are struggling with heart failure.
Very good point, Dan. And that takes us to the next point, actually. And we talked about patients on inotrope drips, but we have in our program, we have a lot of patients with actually LVADs, right? And they come in with their batteries and they hop on the treadmill, and that's what you want to help them. It's the confidence that they can do this. The professionals that are dealing with the patients are trained to deal with this patient, to deal with emergencies, how to replace the batteries, how to detect any malfunction, how to monitor their blood pressure if someone has an LVAD. So, Michelle, what would you say to reassure and the patients? I mean, our attendants here about patients with LVAD.
Well, in general, patients with LVAD are in better shape than they were before. They're supported. And that's the take-home point, is that patients on inotropes and LVADs, they have support now, and their heart is better than it was before. So all of these patients can exercise. In fact, they're probably a little bit more stable than some of the other patients who are post-procedurals. So I highly recommend in encouraging them to exercise, become more independent, increase their quality of life, and get some of the supports from the people around them that they actually can do these activities.
Yes, so this goes to this next topic, which we very quietly transitioned into, is that after referral, is that how do we enroll patients and encourage them to attend? And that's what you guys have been talking about this helping them with their daily activities. And Stephen, do you think we have to change the messaging specifically for patients with heart failure, or this is part of what we do already?
So again, we've been seeing patients with heart failure and cardiac rehabilitation for decades as part of a comorbid event. And now we're seeing many patients with, let's say, their primary referring index event as being heart failure. But in general, the cardiac rehab delivery in terms of supervision, exercise prescription, outcome measurements, broad education are relatively all the same. We don't change what we do greatly for these patients. Are there some nuances for patients with heart failure? Absolutely. In terms of fluid, fluid intake, sodium intake, in terms of frailty and balance. These are some unique issues that maybe we have to spend some time with. But we're broad enough in our thinking, and our programs are nimble enough to address these as we go along. And so I guess I'd make the argument that we wouldn't withhold patients from coming into rehab because of heart failure. Would it put a little extra strain on the staff that we have to manage a little bit more along the way, or a little bit differently? Probably so. But we would progress them the same and move them through cardiac rehabilitation generally the same.
Excellent.
Can I chime in with one point?
Yes, Dan, please.
Because what I think is, what I would argue is may has changed a little bit, is that the population is getting older. So again, I think that the intake to cardiac rehab, I think, has changed, in that we're seeing an older there's still many young people, but there's a predominance of older people with heart failure. And I think the culture of cardiac rehab has started really mostly towards people that were younger. And I think, as it's been said, even older, frailer people with complexity are good candidates for cardiac rehab. So the messaging is really evolving, and I think there's more of an embrace for people that may not have been referred in the past, people that are frail, people that have muscle loss, people that are falling. Those are the people that may benefit the most. So I do think there is a change, and as Stephen has already said, there's the capacity for really accommodating these patients in a way that's very useful.
Excellent. So we have a lot of, I really want to thank you guys for making this discussion so interactive, and please continue to add points as you see. But this really mirrors what's happening in the chat box. We have a lot of comments there and questions and answers. So I just want to make sure that I share this with the rest of the audience. Someone was commenting whether some suggestion about patients with VAD, and so make sure the cardiac rehab program, make sure you know the direct line to the VAD clinic, because if you have any question, you can call them directly. We have in our program, actually, we have an annual training about VAD and how to deal with emergencies. So the entire staff is actually trained on that on a regular basis. Another program, someone else in the chat box mentioned that you can also invite the caregiver of the patient to come in and be there during the rehab session, because again, as Dan said, this increases the confidence not only for the patient in what they can do, but in their caregiver, seeing them doing that also, and being there. Not only in the professionals, the staff there is probably trained to deal with emergencies, but it helps the caregiver also know what's going on and what is it they can do and what's the worst that can happen, and they're there to deal with it. So this is, I think this is extremely enriching and informative for all of us. Michelle, what do you think about, what other things do you think you can add to patients with already in your heart failure program? What else? What are the other layers that you insist on in your education and your exercise?
Well, I think a lot of the education is covered in cardiac rehab. There's more that can be probably touched upon if you ever want to do a separate class for heart failure patients. But in regards to diet and separate medication regimen, because some of the medications they're on it for different reasons. There's nutrition is a big thing, and a lot of people want to go out to dinner. So what types of education can be done in that regards? And we have our nutritionist at our program has a great class about dining out and making choices from a menu. What are the best choices to make from a menu? But aside of education and supporting them and weighing themselves as frequently, we like patients to be weighed daily so we can see if there's a trend that's happening. Scales are different at every at home compared to at cardiac rehab, but it's really the trend that we want to watch with weights. But I think all of this can be done in helping monitoring their blood pressure and heart rate as medications are being adjusted from their provider.
Good. Yeah, no. So as you said, these are this point, and then as you all said, is this ability to increase their confidence and helping them do that. What might seem not significant to a lot of us, but for them, those few extra feet that they can do on the treadmill, there's confidence to walk in without the fear of falling because of their frailty and advancing age is extremely important. So it's really this improvement in ADLs that's actually quite important. It's not just how much time they spend on the treadmill itself. Another point that I'd like to share from the chat box is someone was mentioning that patients on drips have to choose whether they get home health nursing or outpatient cardiac rehab. And so most patients would choose home health nursing. Apparently, that these are not mutually exclusive, and actually, and this may be something new from Medicare, but you can have both home health nursing for your nursing access and line line support, and you can also attend outpatient cardiac rehab. So that's a good bit of information to share that patients don't have to choose between those two things. What do you guys think about, again, going back to Dan, about the older, frailer patients with or without heart failure? What I'm sure you said many good things so far, but I'm sure you have others to share with us.
From me?
Yes.
Yeah, so no, well, I just wanted to, as you're mentioning, frail or older, I mean, the notion of exercise, I think, really is not intuitive for so you mentioned walking. You can walk at home, but I do think that many of the kinds of patients you just described benefit from strength training, from balance training, and issues about how to organize their medications relative to their exercise. I mean, so there's some fundamental concepts of how to exercise the best in the most meaningful way, which I think is really an opportunity for cardiac rehab. And the other kind of elephant in the room is that heart failure is associated with cognitive decline. Not in everyone, but especially, people that are struggling with age plus heart failure. There's a high percentage of people that do struggle, not necessarily with dementia, but loss of executive function, the ability to organize their lives to be healthy. So I think that cardiac rehab not only helps you to kind of consider what goes into a healthy lifestyle and to maintain that, but how to exercise and how to live in a way that is the most safe and well for as you struggle with the disease. So I think these are all issues that respond to the aging and frailty and complexity.
Good. No, absolutely. I think the medication component is extremely important in terms of reconciliation and also because of the cognitive component of it, but also because of the hemodynamic changes that are observed in this patient population with and without exercise. So I think this is another level of service that the rehab program can provide to the patient and their referring physician. The physicians, most of us in clinic would prescribe something, but we don't see, what does the blood pressure do, for example, for this medication when they start exercising or when they walk, what happens a few weeks later. And so that's information that's extremely valuable in the cardiac rehab program, and that gets circled back to the referring physician. I think, Stephen, I think another aspect that's becoming more and more important is this hybrid or virtual cardiac rehab delivery method, especially in the last 20 months or so with the pandemic, which has even more come up to the front. Do you see something specific for our heart failure patients, or do you see, how do you see that?
So great question, Hisham, and the short answer is yes, yes, and yes. The paradigm for cardiac rehabilitation has to shift in the US for a variety of reasons. Part of it is we have better technology, part of it is COVID, part of it is access for patients who can't get to our facilities. So we are adopting and we are shifting from, some sites will still stay facility-based, but some sites can begin to offer a hybrid program which will have both facility-based and remote, preferably with a virtual telehealth component where a lot of their sessions could be done remotely. An obvious question there would be, well, can this include our heart failure patients? And I guess I would have a couple comments there. First, we tell our heart failure patients now that are stable in rehab, we'd like you to exercise and do some activity on the days you're not in rehab. So we're not necessarily asking you to do other things. And so we would be consistent with that paradigm, so to speak. And the other issue is, again, the HF Action data, which did include a cardiac rehabilitation component, but it also included a huge home-based component, and again showed no difference between the treatment group and the control group in terms of major events associated with exercise or cardiac rehabilitation. And then lastly, we have to look at the big picture. If we want to engage patients we want to spread our network or our net, so to speak, to cover as many patients as we can. We have to engage patients where they live. And that talks about broadening our paradigm, broadening our concept to a hybrid model or a virtual model or a home-based model that includes these heart failure patients in there. And a lot of research now, prior to COVID and in COVID, has been driving patients and have included heart failure patients and have been driving patients in the model of a hybrid or a home-based model.
Excellent. Yeah, I think that's, as you said, cardiac rehab activities, and especially what we ask the patients to do, and both in terms of safety and functioning, doesn't stop when they leave the cardiac rehab door, right? So when we ask them to exercise, or when they're exercising once, twice a week, they still have another 5 days a week that they could exercise. So, expanding, we know that there is a dose-response relationship between cardiac rehab participation and outcomes. And so certainly you can see that going for activities and exercise beyond their physical presence in the cardiac rehab facility. Yes, Dan, please.
Just a rejoinder, just to emphasize the fact that very few people now go to cardiac rehab in terms of the opportunity for growing enrollment is vast. So I think these new models of care respond to a need, perhaps not for everyone. And I think the notion of who does best with home and hybrid is the kind of work that is still evolving in strategies. But I think the model, it kind of was proven in the COVID world that we needed new models of care to respond to different circumstances. And heart failure, with or without COVID, identifies populations that may not really want to come to the hospital. So I think having different options and different strategies is really it's where we are as a medical system, and responding to patient needs, patient complexities, the logistics of rural health, and all other kinds of impediments to getting to the hospital.
Absolutely. I think we could not agree more. We have to expand the offering to reach as many patients as possible. Patients who are close and far away, and that's where we have this whole pandemic of health disparities and health inequalities. This is where another area where this intervention can actually maybe minimize those. So maybe I think, because this is such an enriching discussion, I can't believe that we're almost at the hour here. And this has been tremendously interactive, and I see still a lot of participation in the chat box. Maybe last few minutes, I'd like to discuss about, from a program perspective, within your centers, what else can you do to assess how well your center is doing? How can you improve on that? And what is the messaging for your staff and your hospital system? So how do we evaluate success for this particular patient population? Dan, what do you think?
I'll start, but I'm really curious what the other panelists think too, because we have kind of an argument within our hospital. We talk about, is it the number of sessions you attend? And you talked about the dose response, and there's some logic for that. So who goes to cardiac rehab, who graduates, how many sessions do they attend? And then there's me, who argues it's function. It's what's measurable as a performance measure at the end of cardiac rehab. Does it really impact on people's lives and quality? Does it matter how many sessions they go to if they really feel like they're substantively better and improved and independent? So so there are different. So for performance measures, there's a smorgasbord. 6-minute walk, gait speed, balance test, the short physical performance battery. We talk about, and we've used these. We're studying them, but I think still looking at performance measures, how many sessions is also very important. So I'm curious what others think.
Michelle?
Dan, I have to completely agree with you. I think I personally think that the functional capacity and them to be able to improve, become more independent, gain confidence, and that they have the ability to exercise should really be the main focus of these patients. And it's great if, our goal is for everybody to complete their program and look at the number of sessions that they attend in, but functional ability and quality of life is my number one goal for my patients.
Stephen?
Yeah, so Hisham, just two thoughts I'd like to add. One is there are disease-specific quality of life instruments that we can use for our heart failure patients. Minnesota Living with Heart Failure Questionnaire, Kansas City Cardiomyopathy Questionnaire. Those are two that staff could think about. The second thing is just to put heart failure in the U.S. perspective. The national data suggests, and this is Medicare data, that only about 2 to 3% of eligible heart failure patients get into cardiac rehabilitation. This isn't anywhere near the already low 24, 25, or 26% that we talk for the non-heart failure patient. So I would challenge the people on this call that part of your process improvements would be, and you can put numbers around this and measure this and look at your denominators, et cetera, but try to actively grow your heart failure population in your programs. And that might mean working with the medical floors. That might mean working with outpatient cardiology groups. It might mean working with the heart failure group, which is a natural place to start. But to set as a target, we want to grow our percentage of our numbers of the percentage of patients that are in cardiac rehabilitation. That's a realistic and measurable objective.
Excellent. I think that's a very good point, Stephen, about something that we can measure at the local level and see how we can improve on that. I mean, those all have been excellent points that you've shared with us and from the audience participation. I'd like to also just point out that Take Heart, which is the AHRQ's initiative to increase use of cardiac rehab, specifically actually is designed to improve the participation and use of cardiac rehab. The evaluation process and the patient population that's being targeted by this is really patients with coronary artery disease, so myocardial infarction, coronary bypass surgery, coronary revascularization, and stable angina. So heart failure is not officially part of this initiative, but obviously the implementation of automatic referral and care coordination can certainly expand beyond those diagnoses that I just mentioned to include heart failure and others, and really get to the greater goal that we're all looking forward to, is increasing the use and participation in cardiac rehab. And I think we're almost at the top of the hour here. So I don't know if there are any other bookkeeping question that Stephen would like to bring up. I want to thank you for this very lively and enriching session, guys.
Yeah, thanks very much, Hisham, Dan, Stephen, Michelle, for great insights. And thanks to the people in the other participants in this event for your comments, your questions. We know that there were a number of questions in the chat that we weren't able to answer today. We'll try to circulate responses to those questions along with the event summary and the slides for the event that we will pass on to everyone on this event, as well as to others on our mailing list in roughly a week. There are some resources that were referred to on the event today and others that may be useful for you as you work to support your heart failure patients. You'll see those here briefly, but those are also in the slides that will be circulating to you along with the event summary. So just as we wrap up, we will let you know when our next affinity group is planned for, and we will be delighted if it's as exciting and insightful as the one today. We want to encourage you to continue using the website and the many resources from past events, as well as the opportunity to dialogue with peers is available on that. And then we always are looking to improve what we do on this project. And so the feedback questions that you'll see as you close out, we'd welcome your input on those so that we can learn what we're doing and what we can do better in order to better support your needs. So thank you again for being with us this afternoon. Thank you for the investment that you're making in strengthening the care for all of your patients, including those with heart failure, and just for your ability to persevere in what we know continue to be challenging times. Have a great rest of your day, and thanks again to our panelists for their incredible contributions. Bye, everyone.
Bye.